Ever feel like medical school just throws information at you faster than you can possibly absorb it? Like your brain's meant to be a sponge, but really you're standing in front of a fire hose, especially when you're trying to really nail down something as fundamental but still kind of tricky as the upper arm and elbow. Well, welcome to the deep dive. Today, our mission is pretty clear. Cut through that fire hose blast. We want to distill the essential knowledge of the upper arm and elbow. We're going to try and transform those complex anatomical details into clear, memorable insights, things that stick not just for your next exam, hopefully, but for your whole clinical career. We'll explore the bones, the muscles, nerves, vessels, and yeah, those all too common injury points. We'll use some mental anchors, vivid descriptions, and a bit of critical thinking to help make this crucial anatomy really resonate with you. Okay, let's start with a clinical challenge just to get those neurons firing. When we talk about the humerus, the single bone of your upper arm, there's a specific spot called the surgical neck. Now, if you see a patient with a fracture right there, which critical nerve should immediately pop into your head as being at severe risk? And what functional deficit would you immediately start looking for? Just kind of hold that thought. We'll definitely come back to it once we've mapped out the bony landscape a bit. All right, let's get started on this journey, beginning with the bony blueprint of the arm, the humerus.
Yeah, absolutely. And it's a great place to begin, really, because the humerus isn't just, a simple rod. It's quite a marvel of biomechanical engineering. Take the bicipital groove, for instance. What's really fascinating, I think, is that it's not just some channel. It's like this meticulously engineered tunnel. Its whole job is to guide the long head of the biceps tendon. And this detail, which sometimes gets overlooked, explains why it's such a common spot for tendinitis.
Ah, okay, because of friction.
Exactly. When that tendon experiences these, immense frictional forces, especially with repetitive overhead stuff, think throwing, swimming this groove becomes a real focal point for inflammation and pain. It's like a daily testament to the body's engineering under stress.
That makes sense, thinking of it as a track under constant friction. And speaking of critical pathways, as we move down the humerus, we hit the mid-shaft, specifically through the spiral groove on the posterior side, the back. This is another area that rings alarm bells clinically, right?
Definitely. High-risk zone.
Okay, so second challenge for you listening. If a patient comes in with a fracture right through that spiral groove, which specific nerve and artery are you most worried about damaging? And what kind of functional deficit would you expect to see? Again, just file that away for a moment. We'll connect the dots very soon.
So continuing down the humerus, we get towards the elbow end, and the trochlea really stands out.
The trochlea.
Yeah.
Yeah.
And this isn't just a guide. It's like the biomechanical masterstroke that effectively locks the ulna into a pure hinge motion, like a door hinge, this unique kind of spool-like shape. It actively prevents any unwanted side-to-side wobble, which would seriously mess with the precision we need for, all those fine motor tasks with our hands.
Wow. Okay, so it's really about stability and directed movement.
Exactly. It's a prime example of form dictating essential function really profoundly.
That precision is incredible. And speaking of prominent bony landmarks defining the elbow, we can't ignore the epicondyles, those bony bumps you can feel on either side near your elbow, especially that medial epicondyle, which is kind of infamous because of that nerve, the one we've all probably whacked at some point.
Oh, yeah. The funny bone.
The funny bone. Not so funny when you hit it.
Definitely not. And that's because the ulnar nerve passes directly posterior, right behind the medial epicondyle. That's the precise anatomical reason why hitting it feels like, well, an exposed electrical wire. It's actually a stark reminder, isn't it, how some really vital structures are left surprisingly exposed in our bodies.
Yeah, it really is.
And clinically, if you find specific pain or tenderness over either epicondyle, medial, or lateral, it often points towards tendinitis, usually linked to repetitive strain, again, clearly showing how our daily activities, impact our anatomy.
Okay, so earlier we posed that challenge about a surgical neck fracture of the humerus. Knowing a bit more about the bone now, what's the critical nerve that should immediately come to mind, the one at risk? And what would that mean for the patient?
Right. So the clinical significance here is that the surgical neck is, well, it's a common fracture site, and that's mainly because it's a relatively narrow, sort of mechanically weaker point just below the head of the humerus. The critical nerve running right by there is the axillary nerve, C5, C6.
Axillary nerve, okay.
Yeah. And damage to this nerve means you'd immediately expect problems with shoulder abduction, that's lifting the arm away from the side of the body, and also sensory loss, like numbness over the rounded cap of the shoulder, the deltoid region. It's a classic presentation you really need to recognize.
Got it. Axillary nerve abduction problems, deltoid sensation loss. And for our second question, the midshaft fracture through the spiral groove, what's the verdict there?
Ah, yes, the spiral groove. That's a crucial but unfortunately quite vulnerable pathway. A fracture right through it puts the radial nerve and the profunda artery in serious jeopardy. They run together in that groove.
Radial nerve and profunda artery.
Correct. And given the radial nerve's huge role in extension straightening your wrists and fingers, you'd anticipate that characteristic wrist drop. The hand just hangs limply. Plus, significant difficulty extending the digits and usually sensory loss over the back, the dorsum of the hand. It's a really debilitating injury with very clear neurological signs.
These nerve pathways, they really highlight how central the humerus is. But it's not just a simple bone, is it? It acts as this crucial anchor, dividing the whole arm into distinct anatomical neighborhoods, thanks to something called deep fascia. But is this compartmentalization always a good thing? Can these internal walls actually cause problems sometimes?
Oh, that's an excellent question. And yes, absolutely. While these compartments usually keep things very neatly organized, they can definitely become problematic. See, the arm is wrapped in this tough sheath of deep fascia. And from this sheath, two strong internal walls, we call them fascial septa, extend inwards and attach right to the humerus. This effectively splits the arm into an anterior or front compartment and a posterior or back compartment. Each has its own muscles, nerves, arteries. Very organized.
Okay, like little anatomical apartments.
Kinda, yeah. But here's the catch. If swelling occurs within one of those compartments, maybe from trauma, like a bad break, or bleeding that tough fascial sheath, it can't really stretch much. So the pressure inside builds up and up and up. That's compartment syndrome.
Ah, I've heard of that. Sounds serious.
It's extremely serious because that rising pressure starts squeezing the very nerves and blood vessels the compartment is supposed to protect. It can cut off blood flow and nerve function, leading to irreversible damage if it's not treated fast.
Wow. Okay, that adds a really important clinical layer to understanding these divisions. Let's delve into the anterior compartment first. The arm's flexor powerhouse, you could call it. This is home to the biceps brachii, the coracobrachialis, and the brachialis muscles, your primary muscles for, bending the elbow, doing curls. Expert speaker, what are their neural and vascular masters?
So their main nerve supply is the musculocutaneous nerve, C5, C6, C7. And the blood comes primarily from the brachial artery. What's often overlooked, though, is how precisely this nerve navigates through these muscles. Sometimes it actually pierces right through the coracobrachialis muscle itself.
Really? Goes through the muscle?
Yes. It's quite an intimate relationship, and it means that if the musculocutaneous nerve gets damaged high up in the arm, say near the shoulder, it can immediately knock out the function of all three of those powerful flexor muscles.
That's a fantastic point. So a high lesion means all three flexors are potentially compromised right away. Just underscores how critical knowing these pathways really is. And within this compartment, we also find the bicipital aponeurosis. Now, that's a structure that sounds interesting.
It truly is. It's this broad, flat, tendinous sheet, almost like a natural bridge or maybe an apron. It passes downwards and medially, so towards the inside, from the biceps tendon itself, and it blends with the deep fascia covering the forearm muscles. Crucially, it lies right over and sort of shields the median nerve and the brachial artery as they cross the elbow joint. It forms a protective roof over that cubital fossa area, a vital crossroads we'll definitely get to later.
Okay, good protection. And what about the long head of the biceps tendon itself? The one traveling in that intertubercular groove we mentioned earlier.
Exactly. Inflammation there, tendinitis, is a very common cause of localized shoulder pain, especially anterior shoulder pain. And when it ruptures, tears away from its attachment up on the scapula at the supracondylar tubercle, which often happens more from chronic wear and tear than one single big injury.
Oh, okay.
That's when you get the dramatic Popeye deformity. The detached muscle belly just retracts down the arm and bunches up, forming this prominent, often startling ball on the front of the arm.
Popeye deformity, right. I can picture that.
Yeah, it's always striking to see how clearly anatomy can manifest pathology like that. I remember a case study, actually, where a patient just thought it was a weird muscle spasm, didn't realize the tendon can completely torn.
That visual definitely helps cement the impact. And the main biceps tendon, the distal one, attaches down onto the radial tuberosity on the radius bone.
Correct, and an avulsion there where the tendon basically rips off, taking a small piece of bone with it. They can also be quite debilitating for elbow flexion and supination, turning the palm up.
And speaking of the biceps, tapping its tendon down near the elbow, that tests the C5, C6 reflex, doesn't it? A quick neurological check.
Precisely. It's a key part of the upper limb neurological exam. And while we call it the anterior compartment, it's also like a major highway through the arm. The musculocutaneous nerve lives here, yes, but the median nerve and ulnar nerve also travel through it, along with the brachial artery and the basilic vein. Interestingly, the radial nerve, even though it's mainly the nerve for the posterior compartment, actually makes a brief appearance down in the lower part of this anterior compartment as it heads towards the forearm.
Okay, so it's a busy neighborhood. Now let's pivot to the back of the arm, the posterior compartment. This is your extensor engine, right? Primarily containing the triceps brachii, the big muscle on the back, and the smaller inconius muscle. They're your main players for straightening the elbow.
That's right. And its primary nerve supply, as we touched on when discussing that midshaft fracture, is the radial nerve. Its blood supply comes mainly from the profunda brachii artery, which runs with the radial nerve, and also some branches from the ulnar collateral arteries.
Okay. And this posterior compartment, as we now know, is a maze of important pathways, that midshaft fracture concern. That's precisely why it's so worrying, because the radial nerve and profunda brachii artery travel together through that radial or spiral groove on the back of the humerus. They're essentially roommates in a rather vulnerable spot.
Exactly. And what's crucial to understand about these nerves is their dynamic paths. They don't just stay put. The radial nerve, for instance, along with the radial collateral artery, doesn't stay posterior the whole way down. It actually pierces through the lateral intramuscular septum, that sidewall, to pop into the anterior compartment further down the arm near the elbow.
Ah, interesting. It switches compartments.
It does. Meanwhile, the ulnar nerve also does some traveling.
Yeah.
It pierces the medial intramuscular septum to get into the posterior compartment temporarily, and then, importantly, it enters the forearm by passing behind the medial epicondyle.
Right. Back to the funny bone spot.
Back to the funny bone spot, again, highlighting its vulnerability right there at the elbow. The median nerve and brachial artery, thankfully, take a safer route, descending down the medial side of the arm and into the cubital fossa, typically well protected between muscles.
And just like the biceps reflex checks C5, C6, we can tap the triceps tendon just above the elbow on the back to check the C7, C8 reflex, another one of those essential neurological assessments.
Absolutely. And, these simple rapid reflex tests aren't just hurdles for medical school exams. They are incredibly useful clinical tools. They give you a direct, real-time window into the integrity of specific spinal nerve roots.
So if a reflex is off,
Right. If it's absent, or maybe hyperactive, exaggerated, it immediately flags a potential neurological issue. Could be something like radiculopathy. That's when there's a problem, like compression or irritation, right at the spinal nerve root itself. This often presents as weakness or sensory changes, numbness, tingling, in a very specific pattern related to that nerve root. So these reflexes allow for really quick, targeted initial diagnosis.
Okay, moving down from the arms compartments, let's focus on the main event, the elbow joint itself. It's such a critical hinge, isn't it? Linking the humerus to the forearm bones, the radius and ulna, and enabling just so many daily activities we take for granted.
It really is. The elbow is technically a synovial hinge joint, which means it has lubricating synovial fluid within a joint capsule, allowing for really smooth, low-friction movement. It's formed by two key articulations working together. The humeral nerve joint, that's between the humerus and the ulna, which provides the main hinge action, and the humeroradial joint, between the humerus and the radius, which allows for some rotation as well. Importantly, its joint capsule and the synovial membrane inside are continuous with the capsule of the proximal radial inner joint, the joint just below the elbow between the radius and ulna. And that joint is crucial for pronation and supination, those twisting movements of your forearm, turning your palm down or up.
And stability. It's not just the bones, right?
No, definitely not.
Yeah.
Stability is massively reinforced by strong medial and lateral collateral ligaments. You can think of them like strong ropes on either side of the hinge, really preventing excessive side-to-side movement or dislocation.
Okay. And around the elbow, you also find these specialized sacs called bursae, designed to reduce friction, you said, like tiny cushions.
Exactly like tiny fluid-filled cushions. They sit between structures that move over each other, like tendons sliding over bone. The olecranon bursa, which sits right over the pointy olecranon process of the ulna, the very tip of your elbow, is particularly famous, or maybe infamous. You can get inflamed from repeated pressure or friction, leading to bursitis. It's often called student's elbow or miner's elbow.
Ah, student's elbow. I think I know why.
Precisely, from leaning on your elbows while studying for hours. Or, historically, miners kneeling and leaning on their elbows. This is a common mistake. It's not just a muscle problem. It's a perfect example of where understanding daily activities or occupation directly informs pathology, lifestyle directly influencing anatomy and causing problems. Other bursae around the elbow, like the tendinous one under the triceps tendon, or the radial bursa near the biceps insertion, can also get inflamed from repetitive work, things like assembly line jobs involving lots of elbow movement.
Makes sense. Now, the elbow joint primarily allows for two main movements: flexion, which is bending, and extension, straightening. The chief flexors, as we covered in the anterior compartment, are the brachialis and the biceps brachii. And for extension, straightening the arm, the main player is the triceps brachii, particularly its medial head for the bulk of the work, weakly assisted by that little anconeus muscle. But what happens when this crucial hinge, or maybe the bones right around it, get injured? Let's unpack some common elbow problems. Supracondylar fractures. These are fractures of the distal humerus just above the condyles, often seen in kids, right? After falling on an outstretched hand.
Yes, very common pediatric injury, classically from falling onto an outstretched hand, hyperextending the elbow. And they are notoriously tricky because of their proximity to really vital structures passing right in front of the elbow.
Okay, proximity to vital structures. That brings us neatly to our third challenge question. Why is a supracondylar fracture particularly concerning? Specifically thinking about the contents of the cubital fossa, that area on the front of the elbow we'll explore properly next. Keep that question brewing.
And besides fractures, a fall on an outstretched hand can also cause a posterior dislocation of the elbow, especially common in teenagers and young adults. Most elbow dislocations, maybe surprisingly, are posterior, meaning the ulna and radius move backwards relative to the humerus. We name the dislocation based on where the distal bones go.
Okay, posterior dislocation.
And this type of injury also puts the ulnar nerve, remember it runs behind the medial epicondyle, at significant risk of being stretched or damaged.
Right. And finally, overuse. We mentioned tendinitis earlier with the epicondyles. This leads to tennis elbow and golfer's elbow. The flexor and extensor muscles of the forearm, they mostly originate from common tendons near the elbow, and repetitive strain there can cause real pain.
That's exactly it. The forearm flexor muscles, the ones that bend your wrist and fingers, mostly originate from a common tendon attached to the medial epicondyle. The forearm extensor muscles straighten the wrist and fingers originate from a common tendon on the lateral epicondyle. Overuse, like gripping a racket or club repeatedly, leads to micro tears, inflammation, and pain right at these attachment points. For easy recall, just remember these simple anchors. Tennis elbow is pain at the lateral epicondyle. That's the common extensor origin. Think. Tennis players aim for the lateral line of the court.
Okay, tennis lateral line, lateral epicondyle. Got it.
Golfer's elbow is pain at the medial epicondyle. Common flexor origin. Think. Golfers aim for the middle of the fairway.
Golf, middle, medial epicondyle.
Nice.
Excellent anchors. Okay, let's circle back and answer our final challenge question. Why are those supracondylar fractures such a significant worry specifically for the cubital fossa?
Right. The clinical significance here is, well, it's profound. The cubital fossa, which we're about to explore, sits directly anterior, right in front of this distal humerus region where supracondylar fractures happen. So a fracture there can damage the vital contents of the fossa in two main ways. Either directly, from sharp bone fragments actually hitting or cutting the structures.
Ouch.
Or, perhaps even more commonly and just as dangerously, indirectly from massive soft tissue swelling that occurs after the fracture. That intense swelling can literally compress those delicate nerves and vessels within the tight space of the cubital fossa. This can cut off blood supply, potentially leading to a devastating complication called Volkmann's ischemic contracture, where muscle tissue dies and gets replaced by scarred tissue, causing permanent deformity and loss of function in the hand if it's not recognized and treated extremely quickly.
Wow. That really, really underscores the need for vigilance with those fractures. Okay, and that brings us perfectly to the cubital fossa itself, this triangular space right on the anterior aspect of the elbow, a vital crossroads, you called it.
It absolutely is. It's a critical triangular space, clinically essential for everything from finding a pulse, palpating structures, drawing blood from the median cubital vein, which often crosses here superficially, to understanding the pathways of key nerves and vessels as they transition from the arm to the forearm. Its boundaries are important. Clinically, the brachioradialis muscle laterally, pronator teres medially, and an imaginary line between the epicondyles superiorly. But it's the contents that are absolutely paramount for patient safety.
So what does this all mean for you, the listener, in the clinic? Knowing the precise order of the structures within the cubital fossa is invaluable, And thankfully, there's a really excellent mnemonic to help remember the contents, arranged from medial to lateral, so from the inside of the elbow towards the outside.
Yeah, what always strikes me about this region is just how predictable usually the arrangement of these crucial structures is. It's quite neat. From medial to lateral, so starting closest to the body, you'll find first, the median nerve. Second, the brachial artery. And this is often where it bifurcates, splits into the radial and ulnar arteries, usually right within this space.
B for brachial artery.
Third, the tendon of the biceps muscle, heading down to attach to the radius.
T for tendon.
And fourth, most laterally, the radial nerve and its deep branch, which dives deep here.
R for radial nerve, so MBTR.
Exactly. MBTR, medial to lateral, median nerve, brachial artery, biceps tendon, radial nerve.
MBTR, that's a great mnemonic. Easy to remember.
And it really helps us understand the wider context for clinical procedures. Knowing this MBTR sequence by heart is just invaluable. For everything from safely drawing blood, you want to find the vein, usually superficial to these structures, and avoid accidentally hitting the brachial artery, which is right there,
The point.
to diagnosing nerve impingements or vascular injuries around the elbow. Knowing what should be where ensures patient safety in pretty much any clinical scenario involving the elbow crease. It's truly a foundational piece of anatomical knowledge.
Fantastic. Well, we have certainly navigated the intricate landscape of the upper arm and elbow today. We went from the vulnerable surgical neck of the humerus, talked about those unique nerve pathways like the ulnar nerve's journey, explored the specialized yet sometimes problematic anterior and posterior compartments, and finally landed at that vital crossroads, the cubital fossa, with its MBTR contents.
Yeah, we've really tried to highlight the crucial bony landmarks like the epicondyles and grooves, the distinct anterior and posterior compartments with their very specific nerve and blood supplies. We covered common elbow injuries like epicondylitis, dislocations, and those tricky supracondylar fractures, and of course the critical contents of the cubital fossa. Our main aim today was really to help you, the medical student, build a strong and hopefully kind of sticky foundation for both your exams and, more importantly, for your future clinical practice, where this knowledge gets applied literally every day.
Absolutely. And as you continue on your medical journey, maybe consider how this intricate dance between bone, muscle, and nerve right here in the arm is really a microcosm of the entire human body. We've seen areas of, surprising vulnerability like the ulnar nerve at the elbow existing right alongside incredible protective mechanisms like the bicipital aponeurosis. So here's a final thought to mull over. Where else in the body might a slight anatomical variation or repetitive motion we do every day, or maybe an unexpected nerve pathway lead to such significant and distinct clinical consequences? Keep exploring, keep connecting the dots, and definitely keep asking why.